In patients with relapsed refractory diffuse large B-cell lymphoma, it's very challenging sometimes to identify who might be best suited for autologous stem cell transplants. And one of the things that I consider really is sort of how much disease is present at the time that you're considering a transplant or other therapeutics like cellular therapy or bispecific antibodies or other targeted treatments. I truly feel that patients who have early relapse of disease, who have just seen chemotherapy, really likely won't respond to a chemotherapy-based treatment. So going from chemotherapy strategy to salvage chemotherapy and autologous stem cell transplant is probably not the right approach in an early relapsing or refractory patient. Other molecular markers that may signal poor response to treatment like this is there's p53 mutations. They often can be resistant to chemotherapy. And we're seeing now also that loss of CD20 can be a marker for chemotherapy resistance, particularly to monoclonal antibodies against CD20. And so with this in mind, this is when we start thinking about using different strategies. If a patient is fit, we certainly consider CAR T in the second line or relapse setting in patients. And unfortunately, if there's loss of CD20, usually there's still retainment of CD19, where there could be sensitive to CAR T therapy. And if someone's not fit for CAR T, we're thinking about clinical trials. Some strategies that we're using are tafasitamab, lenalidomide-based regimens and clinical trials with this backbone, as well as other targeted agents like loncastuximab, which is also a CD19 antibody-drug conjugate, and bispecific antibodies, although we have to sometimes caution many of these bispecific antibodies also target CD20, so you really want to confirm that CD20 is still present on the lymphoma, which most times it is, where we can then use bispecific antibodies in patients with refractory large cell lymphoma.